so minutes. Good afternoon, everyone. Once again, we welcome you to this session, and we are very glad to have you join us in this afternoon session, very important session where we'll be talking about stroke rehabilitation and physiotherapy in this World Health Day. And it's a really important session and topic to speak about, and I'm really excited that we are all here to have a listen. We have a great presentation lined up for us. I'll be welcoming our chair, Mr. Kennedy Oko Mogire. So Mr. Kennedy Mogire is a principal physiotherapist and head of physiotherapy unit at Kenyatta National Hospital. He's done his undergraduate studies at JKUAT and is currently undertaking his master's in physiotherapy in the same institute. He has a certificate in neurophysiotherapy from the AIMS Institute in New Delhi. He was the national chairman of the Kenya Society of Physiotherapists from 1988 to 2003. He is the founder and first chairman of Kenya Society of Physiotherapists in Nairobi branch. And he has a wealth of experience both in all areas of physiotherapy, apart from the neurophysiotherapy, both in sports physiotherapy, and worked in a number of institutions, both in the public sector and the private sector. So it's a great pleasure to have him as our chair today, and we'll hand over to him so that he can introduce our speaker and take over the session. Karibuni sana. Please feel free to put your questions and your questions at the Q&A section, and we'll have a chance to answer them towards the end. Mr. Mogiro, welcome.
Thank you very much, Dr. Agnes, for this opportunity. And I welcome you all colleagues for this great presentation today. We are very glad to gather this afternoon for this webinar, which incidentally coincides with the World Health Day. This is a World Health Day, is an event which is celebrated on a yearly basis, and it marks actually the beginning of the World Health Organization many years back. And today, we are very privileged, as we have heard from Dr. Agnes, that we have Dr. Naomi Wanshirok now. Dr. Naomi, she holds a PhD in physical therapy, and we are very privileged this afternoon to have her as a presenter. So Naomi, she's a faculty member of the Department of Orthopedics and Rehabilitation, Moi University School of Medicine. She is a graduate of the University of the Western Cape, Faculty of Health Sciences, where she attained her undergraduate studies. She has a graduate training in neuro rehabilitation from Charlotte University, Germany. Currently, she's involved in training undergraduate and graduate students in the College of Health Sciences, as well as offers care and consultant services to patients. She has been a member of the clinical guideline development team in Kenya for the last 4 years, during which period a physiotherapy clinical practice guideline for stroke rehabilitation for Kenya was contextualized. She has several publications in peer-reviewed journals and has co-authored several other publications. She serves as a co-PI or co-investigator on several funded grants. For this topic, stroke rehabilitation and physiotherapy, we are highly privileged because, as we all know, in the field of medicine, and also all of us who are involved in the health sector, that this is stroke as becoming one of the emerging diseases, And one of the most difficult to manage, and especially since it's not only a disease, but it's actually a fatal when it's not well controlled and managed from the concept. So without much ado, I'll just welcome Dr. Naomi Wanshirok now. Please welcome on board and give us your presentation. Thank you.
Thank you so much, Dr. Adi. Thank you, Dr. Agnes, for this privilege. I would consider it a privilege to do a presentation concerning stroke rehabilitation. And I find it very interesting that we are all gathered here, more than 600 people, all interested to understand stroke and how stroke can be managed. I have very serious interest in stroke because I have been a recipient of stroke since one of my relatives was affected by stroke. So it has been my passion, and I would want us all to join and get to understand stroke much better, the rehabilitation of stroke, and how we can rehabilitate these patients with stroke to an extent that they'll be able to become productive members of society. Now, many a times we realize that in this country, when someone gets stroke or a patient suffers stroke, in a way, they're kind of condemned to disability. And it actually provoked my mind to understanding what stroke is and asking myself, how best can we address this stroke impairment post-hospital discharge in such a manner that they can be able to, this individual be able to get back to work and become members of a productive society. So I'll straight away go to my presentation. And the better percentage of my presentation is about assessment and management, because if we were to get down to the details of how stroke comes about, the pathophysiology of stroke and all that, it would literally take an entire day. So Dr. Agnes really understands what I mean when I talk about unpacking stroke in totality. So I'll straight away go to stroke and its impairments and what we can do as a society or as a team of healthcare providers in assessing and managing stroke. So when we look at stroke, post-stroke patients will present with quite a number of impairments. And these are impairments that eventually will affect the functionality of these patients. And I want to look at it from a physiotherapy perspective, because we all have responsibility as healthcare providers in managing stroke. We have doctors who will give medication, irrespective of whether it was an ischemic stroke or hemorrhagic stroke. Doctors will assess the patient, do investigations, understand what has happened, and provide medication or surgery if necessary. Then we have nurses who have a role in taking care of a stroke patient. But finally, in the context of interdisciplinary approach, we have a physiotherapy who is involved in rehabilitation of stroke patients. So some of the impairments that we have seen in stroke patients includes sensory loss, visual problems, weakness of upper and lower extremity as well as the face, altered tone, gait, balance and coordination issues. The patient who will have stroke that affects their speech. Some patients can have cognitive impairment, dysarthria, dysphagia, and some will present with perceptual impairment. So I'm going to concentrate on 3 areas that a physiotherapist is expected to handle. And that is weakness of the upper and lower extremity, as well as the face. Altered tone, which at some point we'll find that it has it's kind of intertwined with altered tone, gait, balance, and coordination, because each one of us has a responsibility in managing this patient. So for a physiotherapist, we are going to look at weakness, altered tone, gait, balance, and coordination. Now, from our diagrams, we can see patients who are presenting with stroke and the kind of gait they present with, the angulation around the foot. We can see the posture as this gentleman walks, and all these are things that affect the productivity of a patient. So how well can we address this? And again, the other question would be, what has been affected? Because we need to unpack what has been affected for us to understand what it is that we are going to do. Now, most of the time, patients present with certain posture. But the first thing that we need to ask ourselves is, what is happening to these patients? Now, to understand the posture and the presentation in terms of the upper extremity and the lower extremity of a stroke patient, the most important bit is first to understand synergies. And we will come to see that synergies is a mechanism where a group of muscles work together to execute a specific task. You realize in every activity that we are doing, not only one muscle that works. So we have a group of muscles, some contracting by reduction in size, some contracting by lengthening, and as a result, we are able to achieve a certain task. Now, there are tasks that require many muscles or many joints. And on a normal person, we can classify this as commands in the brain. And I'll give an analogy, like in a computer or in your laptop, when you press a command and a C, you will get an output of a copy. When you do a command and a V, you're going to get a paste. So in our brains, we have those commands. But after a stroke, those commands are kind of affected. Some of them are affected in such a manner that they become dysfunctional. Then what does the patient present with? The patient presents with something called abnormal synergies. And in abnormal synergies, we are talking about muscles that cannot work in isolation. That when one muscle contracts, it has an effect on another muscle in such a manner that we do not have total dissociation of one muscle group contracting as a group, but it has to pull together another muscle in such a manner that an activity performance will be affected. So the abnormal synergies that we normally find with stroke patients are: one, the flexor synergy. Number two, we have the extensor synergy. And in this case, we are referring to both upper extremities and lower extremities. So we have flexor synergy of the upper extremity and the lower extremity. We have extensor synergy of the lower extremity and the upper extremity as well. Then we have a combination of the two, and we'll come to realize how this combination comes in, and we call it mixed synergy. So in mixed synergy, that is the eventual synergy that we find with the patient. Now, looking at the basic limb synergies of the upper extremity, and in this case, we are talking post-stroke abnormal synergies. Now, for a patient who has had a stroke, they have a flexor synergy and an extensor synergy. Now, the flexor synergy of the upper extremity, you'll find the scapula is retracted and elevated. The shoulder is abducted and externally rotated. The elbow is flexed and the forearm is supinated. That combination gives us a flexor synergy. Now, for the extensor synergy, the scapula will be protracted and depressed. The shoulder will have an adduction and internal rotation. The elbow will be flexed, the elbow will be extended or is in extension, and the forearm is pronated. The scapula is protracted and is in depression. The shoulder is adducted and is internally rotated. The elbow is extended and the forearm is pronated. And the two patients gives us a classical presentation of a flexor synergy, that is patient A, and an extensor synergy, that is patient B. You realize the shoulder, the scapula, the elbow, and the forearm. At patient B, we have a protracted shoulder, an internal rotation, we have an adduction, we have an extension of the elbow joint, extension of the wrist joint, and pronation. Now, when we look at the combination of these two synergies of the upper extremity, now we need to ask ourselves, which are the strongest component of the two flexor and extensor synergy? Now, the shoulder elevation and retraction of the flexor synergy is stronger than the shoulder protraction and depression of the extensor synergy. Shoulder adduction, so the shoulder adduction and internal rotation of the extensor synergy is stronger than the abduction, and external rotation of the flexor synergy. So with the first two statements, we realize that the shoulder elevation and retraction is the strongest component, and that will take the day. The shoulder adduction and internal rotation of the extensor synergy is also the stronger component around the shoulder joint, and that also takes the day. Now, around the elbow joint, we have the flexion of the flexor synergy, which is the stronger component, and it's stronger than extension of the extensor synergy. Now, at the forearm, we find the pronation of the extensor synergy is stronger than the supination of the flexor synergy. Now, looking at all the strong components, therefore, we will have a patient who presents in this manner. Around the scapula, we'll have an elevation and retraction, which is the stronger component of the flexor synergy. Then we have an adduction and internal rotation, which is the stronger component of the extensor synergy. Around the elbow, we have an elbow flexion, and at the forearm, we have a pronation of the forearm. Now, this is the resultant presentation of a stroke patient when it comes to synergy presentation. And as we see many patients walking, we see that presentation of the upper extremity. And that in itself can tell us which muscles are spastic, which muscles are weak, and which movement is possible and which other movement is not possible. Now, this guides us into, as we manage patients for stroke in rehabilitation, what are we supposed to do? And the answer would be break these synergies. For every physiotherapist, for every occupational therapist, when we are looking at management of the upper extremity, the priority number one will be to break these synergies so that we have dissociated movement and full control of those movements. Now, mixed synergies, as like I mentioned earlier, the pattern is derived from combining the stronger component of the flexor synergy and extensor synergy. Now, shoulder elevation and retraction becomes the resultant synergy, shoulder adduction and internal rotation, elbow flexion, and forearm pronation. As you watch every single patient you see for stroke, that's how the upper extremity presents. Now, most of the hemiplegic patients cannot perform movement in isolation because they are synergy bound. Now, most of the muscle contraction, when a patient tries to do one movement, because of the synergies, the entire pattern moves because it cannot at the very early stages of rehabilitation or at the very early stages of stroke recovery, they cannot dissociate one movement from the other. So they're kind of synergy bound. Now, upper extremity flexor synergy is initiated by shoulder elevation. And for those of us who have been rehabilitating stroke patients, you realize when you tell a patient to lift up the affected arm, the entire arm, elbow flexion, elevation all come together because that cannot be separated from the synergy. The rest of the muscles of the synergy follow this activation. Now, of importance to note is some stroke cases might display shoulder hyperextension while trying to perform the upper extremity flexor synergy. Now, as a healthcare provider, as a physiotherapist, as an occupational therapist who is involved in stroke rehabilitation, understanding synergies will help us answer many questions that oftentimes have remained vague to our understanding. Now, some of these few questions are easily performed. Some of these movements are easily performed, and others are difficult to perform. And a good example is a patient who has a stroke and is bound by the flexor and extensor synergy has a lot of difficulties doing the elbow extension. Why? It's the weaker component of the flexor synergy. Of the extensor synergy. Stroke find it difficult to extend the elbow, abduct the shoulder, and supinate. The reason being, it is the weaker component of the synergies. This is so because these are the weaker component of the flexor and extensor synergies. We go to the lower extremities and ask ourselves, what kind of synergies do we find in the lower extremities? We have the flexor synergy and we have the extensor synergy. Now around the hip, we have the hip flexion, hip abduction and external rotation. At the knee, we get the hip, the knee flexion. Ankle joint, we have the dorsiflexion, and at the toe, we have extension. Now for the extensor synergy, we have the hip extension and adduction and internal rotation. The knee is in extension, and around the ankle, we have plantar flexion and eversion. That's something that was omitted. We normally have around the ankle joint, we have a plantar flexion and inversion, and the toe are flexed. Now that is the presentation of the flexor synergy. That is patient A, and the extensor synergy for patient B. Now, when we look at the basic lower limb synergy, we realize that the strongest component of the flexor synergy is the hip flexion, and the strongest component of the extensor synergy is hip adduction, knee extension, ankle plantar flexion, and inversion. So at the end of the day, we're going to realize that the patient will present with hip flexion, hip adduction, knee extension, ankle plantar flexion, and eversion. And for anyone involved in rehabilitation, you realize the patient cannot plantar flex for them to take off during gait as they move, due to the fact that the ankle joint is already in plantar flexion, and therefore the calf muscle is not able to move into activation. Now, mixed synergies, we have talked about the flexion around the hip and adduction, knee extension, foot plantar flexion, and inversion. That is the resultant synergy. Now, something we need to note is that the lower extremity, the extensor synergy predominates and is more stronger than the flexor synergy. And the reason behind the extensor synergy dominating on the lower extremity is because we have a disinhibited cortex, and the cortex is therefore not able to control the midbrain and the brainstem. I normally have an analogy as I teach my students that when you look at the brain, the cortex is the prefect. And the rest of the brain that controls movement, that is the brainstem and the midbrain, are like the other members of class. So when the prefect, who is the cortex, is not around, the other members of class are expected at times to misbehave because they have no control. Or a parent and children. When the cortex, which we might consider as our parent, is not there, the children are bound to misbehave. And therefore the brainstem and the midbrain are actually firing, and therefore we might get unregulated descending motor pathways originating from the midbrain and the brainstem. And when we refer to the midbrain, we are talking about the cerebrospinal tract as well as the vestibulospinal tract from the brainstem. Now, the cerebrospinal tract are responsible to increase the flexor tone of the upper extremity, but fortunately or unfortunately, they do not go beyond the thorax or the thoracic region. So oftentimes they work on the extensor, the flexor muscles around the cervical spine. Now, the vestibulospinal tract controls the extensor tone of the upper extremity and the lower extremity. Now, with a dysfunctional cortex, we have overactivity of the vestibulospinal and cerebrospinal tract. And therefore, we have motor discharges from the two pathways, which remain unregulated. There is no prefect, we do not have a parent, and therefore they're just excessively firing, causing increased tone on the lower extremity and the upper extremity. Now, an ankle eversion is not part of any synergy. Therefore, you realize a patient is not able to do voluntarily at stage 1 or stage 2 or stage 3 of stroke recovery. They're not able to perform an ankle eversion. Now, having had the two synergies, this is the presentation of a stroke patient. And I want to believe many of us can identify with this. We've seen patients presenting this way. We've seen patients having that gait, and that is a result of extensor and flexor synergy of the upper extremity and the lower extremity. And this, again, understanding it will help us answer many more questions. Now, when a patient tries, when we look at that patient, when he tries to take the limb forward, that is the limb of the affected side, along with the hip flexion, we see hip adduction, and that was a stronger component of the extensor synergy. We see a knee extension, plantar flexion, and an inversion, and we can identify with that quite a lot. Understanding synergies will answer many questions, and one of the questions is, why are there challenges maintaining an upright posture? We realize that the stronger component of the flexor synergy of the lower extremity is hip flexion. So a patient will always try to stand with a flexed hip. For anyone who understands motion and gait, it's very difficult for an individual to stand with a flexed hip. Why? The second question we need to, or can be informed by analysis of synergies, is why there is less weight bearing on the hemiplegic side. Why is in a hemiplegic gait there is increased swing time and decreased stance time on the affected side. And finally, why hemiplegic patients struggle to with activation of the knee flexion and ankle dorsiflexion. And that, again, the synergies will tell us why. Then we come to stroke recovery. Having understood all that, then what is stroke recovery and what are the stages of stroke recovery? Now, stroke recovery, during this period, we have stereotypic sequence of events taking place during the process of stroke recovery. And these sequences or the stages can be divided into 7 stages. Now, we normally classify it into 7 stages, but in terms of rehabilitation, we go up until the 6th stage, because the 7th stage is full recovery, and therefore there is literally no rehabilitation that is needed. Now, each stage has certain key characteristics and features. When we're looking at stage 1, we are asking ourselves, where are we? Now, at stage 1 is immediately after a stroke, and many of the patients will present with flaccid paralysis of the affected side. At this point in time, we do not have any movement of the limb, and the patient has hypotonicity and has complete areflexia. Then we come to stage 2. Now, at stage 2, things start happening, and we have the development of spasticity, both in the upper limb and the lower limb. Now, the first thing we need to ask ourselves, for us to move, and all the physios and the OTs need to ask themselves, at stage 1, we have complete paralysis of the affected side. And we have a reduced tone, we have a complete reflexia. Then what are we supposed to do? Then our management needs to be guided from stage 1. Now at stage 2, we have development of spasticity of the upper extremity and the lower extremity. Spasticity develops first in the strongest component of a flexor and extensor tone. And in this case, we are looking at the biceps. Just an example, the biceps and the quadriceps muscles. Basic limb synergies get initiated as an assorted reaction. Now, at this stage, we see some synergy coming on board. And these synergies come in as an associated reaction. Now, what we mean by associated reaction? Now, what we mean by associated reaction is when a hemiplegic patient put extra effort on the normal side, assume a therapist is resisting hip adduction of the normal side when the knee is flexed bilaterally, then you will realize that there is a reflexive stimulating reaction on the basic limb synergy of the paralytic side. What that means is when a therapist resists movement on the non-affected side, a similar contraction is elicited within the basic limb synergies on the paralytic side. And this is one of the components that we normally use to initiate a contraction or to initiate reflexive activities on the non-affected side for a patient at stage 1. And we would normally call it homolateral limb kinesis. And the initiation of the reflexive stimulation on the affected side, we call it Remestes phenomena, which was discovered by someone by the name Remestes. So some patients may exhibit voluntary contraction on the paralytic side at stage 2. So this is the very basic stage that starts giving us contraction, whether voluntary or involuntary, but at least we have some contraction. Then we come to stage 3, and at stage 3, we have spasticity reaching its peak. Now, spasticity is positive, but at times it can be very complicated to manage spasticity. So at some point in our learning, we'll learn how to manage spasticity for hemiplegic patients. Now, at stage 3, the patient gains voluntary control of movement of the synergies, although full range is not developed. So the patient will initiate some movement, but in as much as that movement comes within the synergy, the patient cannot pull that limb to full range of motion. And we consider this stage a semi-voluntary control stage. Patient can initiate movement, but has no control over the outcome of the movement. A patient will try to flex the limb or flex the upper extremity, flex the elbow, but as he tries to flex the elbow, the movement will come within the flexor pattern, and that is the shoulder elevation, shoulder retraction. So all that will be within the synergic pattern due to the fact that it's already synergy bound. Now then we come to stage 4. Patient can initiate movement outside the limb synergy. So at this point in time, patients are able to try and dissociate the movement or the contraction of the muscles. They can at least initiate dissociation of muscle contraction. Now, some movement combination that do not follow the energy are mastered, but at first with a lot of difficulties, but later it eases down. Now, at stage 4, spasticity begins to decline, but can still interfere with movement outside the synergy. A patient has to use more energy to produce movement outside the limb, basic limb synergy, and spasticity starts to decline and movement becomes easy. Now, how do we get to know that the patient has gotten to stage 4 of stroke recovery? There are certain key things that we're supposed to observe, and this will tell us whether the patient is at stage 4 of stroke recovery. So number 1, on the upper extremity, you need to assess whether the patient can have the hand behind the body. And that will tell you that the muscles are starting to dissociate in such a manner that they can perform movement independently. The second one is pronation and supination with elbow flexed at 90 degrees and adducted. Now, what that tells us is the patient is able to dissociate pronators from the flexor synergy, and therefore we are talking about the biceps muscle. So in other words, a supinator can contract without the contraction of the biceps muscle. The third test is assess whether the patient can have the upper limb horizontally elevated with elbow extended. And that will tell the therapist that the patient is able to dissociate the pectoralis muscle contraction away from the triceps. And therefore, that will tell us that this patient is already in the stage 4 of stroke recovery. How do we assess whether the patient has gotten to stage 4 of stroke recovery when it comes to the lower extremity? Now, we are looking at movement outside the synergy, which includes knee flexion beyond 90 degrees. If a patient can be able to flex the knee without any other joint moving past 90 degrees, you realize that this patient is getting to stage 4 of stroke recovery. Ankle dorsiflexion without lifting the foot off the ground. So the two are just the assessment that we can use to assess stage 4 of stroke recovery. And one thing that we need to note is that not always do we have the upper and the lower extremity fall in the same category or in the same stage of recovery simultaneously. Oftentimes in my practice, I've realized that you can find the lower extremity at stage 5 or stage 4, but the upper extremity is still at stage 2 or stage 3 of stroke recovery. So they do not move simultaneously. So this is just an example of how to identify whether the patient has gotten to stage 4 of stroke recovery when it comes to the lower extremity. Now come to stage 5. Now at this point in time, the patient is able to do more difficult movement. At this point in time, the more difficult movement are learned and the basic synergies start losing their dominance. A variety of movement are mastered from the paretic side as synergies disappear. Spasticity starts to decline. Now, there are key things that we can do to determine that the patient is in stage, this is 5, it's supposed to be 5, sorry, stage 5 of stroke recovery. And on the upper extremity, it's supposed to be, you assess the upper limb, whether the patient can go beyond 90 degrees in horizontal elevation. The second thing is you check for the upper extremity, if the patient can be able to go to 90 degrees in abduction with the elbow extended, and whether the patient can be able to do elbow extension abducted to 90 degrees and is able to do supination and pronation. When all these 3 can be performed, then the patient has gotten to the 5th stage of stroke recovery. Now at stage 6, we have disappearance of spasticity and the individual joint movement becomes possible and coordinated approaches near normal. Wide spectrum of movement combination is possible and normal motor function is almost restored. Now at this stage, we might consider the patient almost as near normal as possible, because the next stage would be stage 7, where the patient goes back to normal. So oftentimes I've seen my patient get to stage 6, but they hardly get to stage 7, where, because you still see some residual deficits. Not so much, but at least you can do some observation and see that the muscle contraction is not as normal as it was before stroke. Stage 7, we have the restoration of normal motor function. Patient becomes completely independent and can be able to perform activities of daily living in a purposeful and coordinated manner. And that person can get back to full functional activity. When it comes to management, having understood what happens when it comes to functioning, motor functioning, and gait and posture and all that, then the first thing we need to ask ourselves, then how do we get this stroke survivor from the impairment that he has gotten into up until he recovers fully? Then we're going to look at management, and I'm talking about rehabilitation of stroke survivors. Now, patients and carers' needs and wishes are identified and quantified. Many patients normally complain of the fact that when they come to the facility, we hardly sit them down to understand what their wishes are, but we do our assessment and we structure our management, not putting into consideration the wishes of the patient and the carer. So number one is to identify what their wishes are and what their needs are. Then we factor them into our treatment program. Then we sit down as the patient, the members of the family or whoever is responsible, and the healthcare giver, and identify goals that they need to work on. They can have long-term goals, medium-term goals, as well as short-term goals. Then we come to intervention. Now, interventions are meant to assist the achievement of these goals. And finally, we need to do a reevaluation or reassess. Now, at the initial stages, we've done the assessment, and we are looking, for us, that forms the baseline data for our management. Then after a certain period of time, we need to ask ourselves, where are we? So we have to go back to where we started and then ask ourselves, how far have we gone? So there is need for reevaluation or assessment, reassessment of the patient after implementation of some assessment, some management, sorry. Now, there are two stages of management when it comes to rehabilitation. We have patients who are bedridden, and these are patients who are probably in the ward, and at that point they require physiotherapy. But many a times you realize physiotherapy for a stroke survivor in the ward is more of taking care of a bedridden patient more than stroke rehabilitation. So we have an acute stage where for bedridden patients, we might get into positioning, because these are patients who have no bed mobilities activities. So therefore, we will be positioning them. Now we can look at 5 main positions which are recommended for stroke survivors. And we have lying on the affected side. We do, and my colleagues do understand the positioning as we do the positioning on the non-affected side, lying on the affected side, lying supine, sitting up in bed, sitting up in a chair. And I have a diagram that can probably shed more light when it comes to those positioning. So these are some of the positioning that we normally do for bedridden patients who have survived a stroke. Now, the main part where physiotherapy and rehabilitation is key, and the results can be seen post-admission, is outpatient rehabilitation, or the continuous rehabilitation post-hospital discharge. Now, we have one of the things that we need to take care of is the shoulder. And I believe for anyone who has had an encounter with shoulder subluxation has been a main problem that they always complain about. So we need to look at the shoulder management. Therefore, shoulder pain is the most common complication for stroke, with 70 to 64% within the first week. So after discharge, or even while still in the hospital, patient will complain of the shoulder. And this is expected because of the flaccidity that comes with stroke. And shoulder joint being a musculature joint, it has very little support post-stroke, and therefore it's predisposed to dislocation and subluxation. Now, what makes the shoulder susceptible? Now, the flaccidity in early stages of hemiplegia leads to compromised glenohumeral integrity. We have static stability of the shoulder is lost, and this can lead to inferior anterior migration of the head of humerus, and therefore we get a sulcus sign. Now, abnormal stretch of the periarticular structure of the shoulder joint due to ischemic change, hence pain and inflammation. So all these are causes of shoulder challenges, shoulder pain, shoulder instability that we're going to face post-stroke. Now, how do we manage these shoulder?
Naomi, are you there? Sorry, we seem to be having some internet problem, but she'll come back.
Yes, any question?
You went off briefly. There's a question.
Okay. Yes.
I don't know whether we can deal with the question right or you finish when then we come to question and answer.
I would suggest we finish the presentation first, then we can have the question and answer session.
Beautiful. Then go.
All right. So I'm looking at the management of shoulder complication, and one of them is shoulder support. Now, in the past, some of us have used a shoulder, a sling for shoulder support. And the challenges of a shoulder sling is the fact that, in a way, it's supporting the complication of the synergies adduction. So what we need is to have the right shoulder support at the right time. Now, that shoulder support will prevent subluxation and maintain glenohumeral integrity. It will also need to be cosmetically sound, because I mean, we are all human beings. You don't need to use a gadget that you don't feel like you can get out of the house with that gadget. So it should be cosmetically sound and allow upper extremity available for other exercises. Should prevent pull of shoulder by downward acting forces and maintain glenohumeral integrity during range of motion exercises of the upper extremity. Now, the shoulder support should facilitate flexor spasticity, should not facilitate flexor spasticity in hemiplegic or hemiplegic patient, and we're looking at the upper extremity. Arm sling facilitate flexor spasticity in bicep muscles and adductor spasticity in pectoralis muscle. So a sling will not help us as much because part of the problem will be facilitated. And at the same time, the sling will hold the elbow joint and probably the wrist joint in place, and therefore we are not, those two joints are not available for range of motion exercises. So rehabilitation targets reduction of pain around the shoulder, reposition of shoulder subluxation or reposition of the subluxed shoulder. And this requires high compliance with the patient and the doctor. So as fast as possible, let us regain stability and function. And this can be achieved through different approaches. We have motor relearning, we have need-specific task, and we have compensation movement. Now, this is an example of the shoulder support. And if you look at this lady standing, the shoulder support kind of takes the shoulder joint back into its normal articulation. The elbow joint is also taken care of, and therefore that eliminates the pattern of flexion around the elbow joint. The shoulder, the fact that we normally get a shoulder elevation and retraction when a shoulder support is used, we get the shoulder and the posture coming into place, and therefore the posture, as we saw a little earlier, that posture is one of the impairments that we have with stroke patients. So use of a shoulder support will stabilize the shoulder joint and the elbow joint, as well as change the posture of that patient. So this will reduce stress. So we have reducing and stabilizing shoulder orthosis, that is a shoulder support, and improves body posture and gait. This is also another example of a shoulder support that takes care of the shoulder and takes care of the elbow joint in a manner that does not facilitate the patterns, the flexor and extensor pattern. Repositioning of the shoulder joint cover the loss of muscle stability, minimizes the weight of the arm, prevent spastic episode, and free arm so that the arm is able to do more and more exercises. And at this point in time, we have realized over time that it alleviates pain by 50%. So this is just an example of how a patient without a shoulder support has a deviation when it comes to posture. And on the other side, with a shoulder support, the posture is already taken care of. So shoulder support, elbow support, there's some other supports gadget that will support the limb, the upper extremity, all the way to the wrist joint. And therefore, we are likely not to get stiffness or contractures around the elbow joint and the wrist joint. A good example of gait and posture, if you look at the gentleman on one side without a shoulder support, we have a shoulder elevation on one side and a shoulder depression on one side. After the fixation of the shoulder support, the posture comes right, and therefore the gait is improved. So we do shoulder and we participate in improving gait. The quality of a good shoulder support should provide stability to the glenohumeral joint. We've talked about the cosmetic aspect, should permit range of motion exercises or weight-bearing activities, and should be easy to wear for the stroke survivor. Now, the shoulder joint, we also need to do proper handling and positioning of the shoulder, especially for patients who are in acute stage, so that we don't get into shoulder dislocation and subluxation. And for patients who still have pain, we can do joint mobilization. We are talking about grade 1 and grade 2 of Maitland joint mobilization. Now, one of the things that we've done personally in the past is the use of heat to manage shoulder pain. And literature has it that heat is contraindicated for one reason. These are muscles that are already weak, and the use of heat will make the muscles weaker because heat comes in with muscle relaxation. Use of overhead pulley. Now, any movement of the shoulder joint before it stabilizes should not go beyond 90 degrees because you're going to predispose that shoulder to shoulder dislocation. So use of overhead pulley is contraindicated. Use of heat therapy is contraindicated. And in this case, for physiotherapy, I'm talking about hot bags, I'm talking about ultrasound. All those gadgets are contraindicated for stroke patients, irrespective of whether they have pain or not. So pain can be managed using joint mobilization. Now let's manage the limb synergies, because we've realized this is what is giving us nightmares and poor gait, poor posture, and all that. So limb synergy management is backed up by neuroplasticity. And Brainstorm approach has it that the execution of normal movement pattern over and over again for reorganization of the brain will happen, and therefore neuroplasticity comes in. Now, having had a stroke, we have infarct, and therefore some neurons have been damaged, but with the remaining neurons, we can do reorganization and retraining so that the remaining neurons can take over take over and normalize the movement pattern by inhibiting the abnormal muscle synergy when necessary. Now, number one step in managing abnormal synergy, we need to introduce a new movement outside the involved synergy. In other words, we are doing something opposite of the abnormal synergy. Now, a good example is with the patient who has a flexor and extensor synergy of the upper extremity. We can remove the shoulder abduction component and replace the shoulder. We replace it with the shoulder adduction. So with the shoulder adduction, we are improving or we are introducing a new component of the extensor on the extensor pattern. Now, design and exercise. The second step would be design and exercise, which involves in this new movement and is integrated into task-oriented activity. What that means is bring in exercise program that can be performed within the normal functional activity, so that as the brain recovers, as the neurons recover or take up new responsibility, they will take up those new responsibility within the functional activity. And as literature has it, the neurons that fire together, they wire together. So the best thing we can do is introduce exercises that will integrate task-oriented activity. And a good example is a patient uses the paralytic hand to touch the opposite side and move it up from the elbow, go to the ear, forehead, back, and at the head, at the back of the head. That initiates kind of a combing activity of the hair. Therefore, in as much as we try to rehabilitate, let us rehabilitate within the functional activity of the patient. Now, step 3, the therapist should demonstrate the new combination of movement by passive movement. So the patient should see the therapist doing it, therefore can engage in the rightful way or the right way of doing that activity. Patients remain as relaxed as possible and the therapist demonstrates. This movement takes place in space or via the sliding movement on the contralateral side, that is the non-affected side. Now, all this movement, all this involves shoulder adduction and elbow flexion. So those are some of the movements that will help us in breaking the synergy. And at this point, the brain registers the new combination of movement. They are goal directed and accompanied by a sensation of touch. Now, when the movements are done and they involve a touch activity, that touch activity sends signals to the brain, and therefore we have an increased sensory impulse into the brain. Increased sensory impulse in a way provokes an increased motor output in a more purposeful manner. And Broomstrom also has recommended stroking or rubbing with paralytic arm, which will increase stroking or rubbing of the paralytic arm, which increases sensory awareness, hence motor output. Now, stage 4 of breaking the abnormal synergy. We can use something called hold after position technique. Many times when we do exercises of the lower and upper and the lower extremity, we tend to do active assisted exercises to our patients, but with the very early stages of stroke recovery, talk of stage 2, patients are not even able to initiate a movement, or can initiate a movement but moves very little. So never encourage the patient to produce a motion from the beginning of the range, start from the end. So the therapist should take that limb to the end range of motion of that particular motion that we want to achieve. Then passively place the limb in the end range position, hold your arm there, and do not and tell the patient not to allow that arm to come down. So what we are saying is you take that limb to the end range that you wanted to achieve. From that point, you start encouraging the patient to do the opposite, so that that muscle, which is already in full range, then it starts stimulating the muscle spindle for it to start initiating a contraction. Now, new patterns need to be put in end range, and all the muscles that are supposed to act to produce that motion will remain in a shortened position. As a result, the muscle spindle remains shortened. When the instructions are given to the patient, these are instructions that at times hold the arm and do not allow me to slide it down. Patient tries to maintain the position of the hand against the push from the therapist. Now, at this point, a contracting muscle, a contracting spindle is stretched, further strengthening of the stretch reflex of the pattern that we want to strengthen. And this is called the secondary ending stretch. Now, train that kind of movement in small end range fast, then increase gradually as patient improves. Now, at this point in time, we are utilizing three contractions, three types of contraction. We are initiating an eccentric contraction, a concentric contraction, and isometric contraction. Now, when we do that more and more, we are going to gain functional activity, and that will give us a combination of movement. And a good example is a combination of muscle contraction that give us hair combing. Now, if you have sensory re-education, I know most of us do not engage in sensory re-education, but what we need to put in mind is it's through sensory input that we get a motor output. For us to get a knee jerk, we have to initiate a sensory input. Therefore, sensory integration or sensory re-education is very important. Now, sensory re-education, we need a cognitive behavior therapy technique, and this will help the patient to meaningfully interpret the altered neural impulses, reaching the cortex or the somatosensory cortex, and after the altered sensation has been stimulated. Now, the repetitive neural input produces plastic changes, or neuroplasticity starts setting in the somatosensory cortex. Now, sensory retraining does improve both the patient cognitive and adaptive responses to stimulation of the affected skin region. And this functional reorganization of the brain is a natural process and depends on the brain capacity to adapt when the body sends new signals. Now, the exercises should be done for a few minutes, several times a day. So this is not, it's kind of provoking the brain on and on, for the neurons that have not been completely damaged to start receiving information and integrating it. Now, for the neurons that have been damaged, we are re-educating the existing neurons to take up that responsibility in a functional way, or receive that information and give us motor output in a functional way. So we need to do sensory re-education exercises for a short period of time, 4 to 6 times per day on a daily basis. And this is more effective than having it longer time, less frequent. Now, start the training soon after an injury when the patient is stable enough to receive therapy. Now, stages of retraining sensory integration or re-educating sensation. Now, we have stage 1 is localization. Now, the intention is to re-educate constant versus moving touch perception. Now, greater stimulus intensity may be necessary for a patient to differentiate constant from moving touch. The intensity should never be so great that it can evoke injury. Now, stage 2 is the texture and shape discrimination. And the intention is to re-educate the directionality of movement, perception of the patient. So when we are educating sensory, we need to have a few equipment. Take an example, brush, a piece of cloth, ball, soft towel, a container of lotion, and a massager. Now the procedure is place the affected part of the body on a couch, use the soft brush, and stroke deeply from the shoulder downwards to the finger. And for the lower extremity, we start from the hip all the way to the foot. Now turn the limb and quickly perform mild stroke backward to the shoulder and the hip. Now do the same with different texture, and you can also do the icing. So this is kind of initiating the somatosensory cortex to start receiving information of deep sensation, superficial sensation, and being in a position to identify the deep and superficial sensation. This has to be done oftentimes up until the patient starts receiving those signals. We can also do positioning of the patient towards the window, that is towards where light is coming from. And we can also do the weight bearing, putting the affected arm in a position where it can bear weight. Take an example, you have the patient, as much as he's not able to stand, help them stand so that they can do weight bearing, as well as joint approximation techniques. We've talked about stroking with different texture, pressure application, and there are also other improvement or treatment that can be done to improve on visual and auditory, but those ones are done by different people, that is the speech therapist. Now we come to spasticity. Now spasticity at times can be nagging in such a manner that it's not even possible to position a patient in a functional position. So interventions to reduce spasticity should be considered when levels of spasticity interferes with the ADLs. Now, we are also not advised to use resting splits of the upper extremity when the patient is not having any activities. Now, for the extreme cases, we've seen doctors do Botox to reduce spasticity for a certain period of time. And during that time, the physiotherapist or the rehabilitative workers are able to manage the ranges of motion and do stimulation as well. Now, we have tone management, and in this case, we are talking about managing tone and managing tone at the stage 1 of stroke rehabilitation. Now, stage 1 and stage 2 of stroke rehabilitation, the key points, all exercises are not meant to increase background tension and are meant to increase background tension, facilitate reflexive movement in flaccid muscles of the upper extremity and the lower extremity. Now, what we are looking at here is these are flaccid muscles. The tone is reduced, and it's only up until we get a contraction, whether reflexive or not, that we can start initiating some movement. So the fundamental principle here is to first of all initiate a contraction. Now, this can be achieved in 3 strategies, and we have 3 strategies. One of them is postural reflexes, and those in pediatrics understand asymmetrical tone neck reflexes, and symmetrical toning reflexes. Those reflexes, these are the primitive reflexes that are normally seen in babies until they dissociate. But when it comes to neurological cases, they become quite instrumental in rehabilitation. Now we have associated reaction. We talked about the associated reaction and the Rebesty's phenomena. And then we have the local facilitation. Associated reaction is where we use the unaffected side to initiate reflexive reaction in the affected side. Now facilitation, local facilitation is like tapping, vibration, where we are initiating a sensory stimuli so that we can get a motor output. Patient voluntary effort with the three strategies will increase the background tension. Rebesty's adduction, we've talked about it, where you use the non-affected lower limb adductors to initiate a reflexive movement on the affected side. Now utilize local facilitation techniques such as tapping, rubbing, and they will all stimulate the muscle spindle. And then we have many exercise variations that we can do. Now, exercise in flaccid stage of the lower extremity, the aim is to increase the background tension of the hip muscles and gain reflexive movement. Patients take the normal knee in flexion. This is just one of the examples of how to go about it. And the therapist takes the affected limb into flexion and supports it at the knee to avoid a fall. Now, first movement is the hip adduction on the paralytic limb. Use the Rebesty's adduction phenomena. With the hip flexion bilaterally, the patient will do resistance of the hip adduction of the non-affected side, and that initiates a reflective movement of the hip adduction on the non-affected side. Now the therapist places one hand medially on the non-affected joint proximally to the knee, while maintaining support on the affected joint. As the patient produces strong effort on the hip adductors muscles of the non-affected hip, the therapist will resist the motion in such a manner that no or very little movement is produced on the normal side. While the patient generates this movement on the normal side, we will see a reflexive increase in the background tension and reflexive movement setting in on the paralytic side of the affected side. The limb that was falling outward will start moving in adduction direction. And the therapist can also do rubbing and tapping over the adductor muscles to further generate background tension by stimulating the muscle spindle. The therapist can also have exercise in which the therapist keeps the hand between the knees and asks the patient to generate a strong contraction from the normal adductor muscles. So this is one of the examples of how to initiate a contraction from the flaccid stage. Now, when the knees are proximate to each other, the therapist takes them to the paralyzed side. Now, instruct the patient not to allow the fall outward, and the resistance is maintained throughout the motion. Now, exercise in flaccid stage of the upper extremity. I've given an example of flaccidity of the lower extremity and how we initiate a contraction. Then let's look at the contraction of the upper extremity. Now, gain mid-range elbow flexion in the paralytic upper extremity. Then we need to utilize local facilitation technique. We can do tapping, rubbing, and all that. We see a reflexive activity in hemiplegic elbow joint. When you do tapping on around the tricep muscles, you're likely to see a reflexive kind of activities on the affected side. Now, gaining elbow flexion in the paralytic side, utilize associated reaction to facilitate tone on the weaker side using imitation kinesis. Performing the same movement of the normal side with resistance as intended to achieve on the affected side. Use a therapist to resist a forceful contraction of the triceps. Let me just make it a little simpler. If you want to get an upper extremity extension of the elbow, you can have this patient have a phone and place it around his ears like he wants to receive a call. Then he does on the affected side and the non-affected side. Then from that point, tell the patient not to allow himself or herself to be pushed outward. So the physiotherapist will try to, physiotherapist will be trying to put pressure around the maintenance of that phone around the ears, while the patient will be trying to pull it off the ears. So in that kind of a manner, we are able to initiate a contraction of the affected side, facilitated by the non-affected side. The therapist resists the movement on the normal side of the patient, and the patient is instructed, do not let me take the mobile away from you. Once the therapist starts getting strong contraction on the normal upper limb, the normal limb group of muscles, the patient is instructed to hold in position from the weaker side, close to the face, and the patient produces isometric or eccentric contraction on the muscles on the affected side, even during the flaccid state. So we are basically looking at some of the resistant exercises to initiate an isometric muscle contraction. Now, the other way we can facilitate contraction is by use of a neuromuscular nerve electrical stimulator. And by so doing, we are using an electrode around the spine and one around the muscle belly. And the muscle, the electrode at the spine will kind of stimulate the gamma fibers that will stimulate the muscle spindle. And once the muscle spindle have been stimulated to contract, they'll pick that information through the sensory, take it back to the central, the spinal cord, and triggers the alpha fibers to stimulate a muscle, and therefore we get kind of a contraction initiated. So we still struggle with spasticity in as much as we do the initiation of contraction, and therefore part of it is the use of orthosis that we mentioned a little earlier. We can do sustained stretches for spasticity and weight-bearing exercises. Then we come to limb rehabilitation. We need to take care of the abnormal synergies, gait-oriented training, and this has been well researched about, partial weight-bearing gait training, and also non-weight gait training has also been recommended. So this is basically talking about neuroplasticity through continuous activation of the muscle through daily activities of living. Now, gait training, we can do functional electrical stimulation for treatment of foot drop, because many patients, like we saw a little earlier, they will present with plantar flexion and inversion, and therefore it has a presentation of a foot drop. And therefore we can do neuromuscular electrical stimulation as well as an orthosis. We have very good orthoses nowadays that are working on the lower extremity, and therefore that dragging of the foot is eliminated. Treadmill for gait training for patients that are independent in walking at the start of the treatment. Repetitive task training, this is done when the aim of treatment is to improve gait speed as well as walking distance. Then we can have the walking aids. Should be considered only after full assessment of the potential benefits and harm of the walking aid. Now, ankle foot orthosis, we've seen foot orthosis from different places, but of late we have walk-in foot orthosis that sorts out the ankle plantar flexion and inversion, and therefore the patient can be able during gait to take off and taking off the ground through full contraction of the calf muscle, and also heel strike as the patient lands on the second step. Now, ankle foot orthosis has an immediate improvement in reduction of abnormal synergy, improves on walking speed, efficiency or gait pattern, and weight bearing during stance, reduces spasticity, and chances of tendon shortening are reduced. In patient prescribed AFOL, regular reassessment is recommended for long-term effects. So this is one of the AFOLs that simply works for the plantar flexion and the inversion. And that can facilitate, if you look at the diagrams above, that will help in terms of dragging the toes and the foot and puts the foot into a functional position. So we have AFOLs that are working, and I think our patients need to take advantage of such so that they are able to work on the synergies. Initial gait training between parallel bars. We can proceed outside bars with aids and then without aids. Walking forward, backward, sideways, and in cross pattern. Then we're talking about a partial weight bearing supported treadmill. With higher speed improves overall locomotion. Then we have proper use of orthosis. Posture, we talked about posture a little earlier when we were talking about the shoulder support. And when we look at the orthosis that covers the knee and the ankle joint will help stabilize the lower extremity to reduce the extensor pattern. And the upper extremity will reduce the flexor pattern, and therefore posture for a hemiplegic patient is sorted out. That is the posture that we're talking about. And I think we are done with that stroke rehabilitation. Back to you, Mugire.
Good, Dr. Ami. I was just about to tell you that you can wind up in a few minutes so that we can have a question and answer. But
thank you.
I hope you are about to. I hope you have about 2-3 minutes to wind up.
I'm actually done.
Okay, thank you very much.
Thanks.
Thank you so much, Dr. Naomi. That was a wonderful presentation, and I'm sure all participants can agree with me. I can see already very, very, very positive feedback, and there are a lot of members who will work to get your notes. I hope you can be able to, we can be able to arrange from this side. Now, quickly, Dr. Naomi, don't get tired, please. These questions is better off when you start answering before any of the participants can also try to assist you, including us here. And I think the first question there is, thank you for this interesting topic. Some patients with stroke or CPA also develop uncoordinated bladder function, abnormal bowel function, or erectile dysfunction. This is from Patrick Musita. They may present with urine incontinence or retention and stool incontinence or constipation. Are there any physiotherapeutic maneuvers to address such?
Yeah, thank you.
We can start with that one.
Yeah, thank you, Daktari. My response to that is the severity of stroke depends on the areas of the brain that has been affected. And in this case, we are looking at the cortex. Now, most of the time we find occlusion of the various blood vessels. We are talking about the anterior circulation, the posterior circulation. Now, depending on which blood vessel has been affected, that will tell us which part of the brain has been affected and what function it controls. Now, when it comes to physiotherapy rehabilitation, especially for the patient that presents with the incontinence and they are not able to go for long calls or short calls. Like I said earlier, we will get into the training of improving motor activity, that is muscle contraction, and therefore slowly we'll be able to achieve at least some contraction. So it's a process. It's actually a process that we start with a few contraction or elicit a contraction, then we build on to that, because there are two principles in neuroplasticity: facilitate the recovery of neurons that were not damaged completely, or retrain the remaining neurons to perform the functions that we want them to function. So we have those two approaches approaches, and we start with however minute the contraction is, on and on, up until we train new neurons to perform that contraction of the muscles, and therefore patients can be able to get benefit from no more incontinence. Back to you, Mugire.
Thank you very much. I think that question you have answered well. For those who are so involved in the interpretation, I think I can totally agree with you that this recovery also goes hand in hand with what we are doing from the acute stage. Now, there was a question there, which is from Miriam Muli. How do we measure shoulder support?
Now, shoulder support, the beautiful thing about the shoulder support, at the moment in the market, we have shoulder support, which is all sizes. So it has such elasticity that it fits into all. We do not have sizes. Once you order a shoulder support, you will get a shoulder support that will fit in for patient. It's all sizes due to its elasticity.
Very true. These days we have companies which are manufacturing what we call universal size, just like a universal size postoperative knee support or range of motion knee support, and it's just a matter of adjusting the straps and it fits very well. Now, we have a question from an anonymous attendee. Thanks for the presentation. An elderly patient with knee joint abduction, possibly due to ligament injury, what will you recommend? Thank you.
I did not get that question correctly.
An elderly patient with knee joint abduction, possibly due to ligament injury, what will you recommend? I don't know whether this is related to CVA or as a general question, because it's from anonymous attendee. This is an elderly patient with a knee joint abduction, possibly due to ligament injury. What will you recommend?
Now, I might not be able to answer that question because this is not a patient I would understand, because there is much more that we need to get concerning this patient for us to be able to prescribe a treatment. And I want to believe the people, my colleagues who are in attendance, agree with me that you cannot treat a patient with just 2 sentences. We need to have a deep understanding of this patient for us to prescribe a treatment. Back to you, Mugire.
I think you are right at this, because this is a general question, and I can see that there is a lot to know from this patient before you can conclusively say what can be done. Now let's go to Hilary Award, and Hilary Award is asking, what is the response in recovery when you consider the distance of the patient from the facility with equipment for attention of the client? What recommendation do you offer to account governors and managers of health facilities?
So my recommendation would be, number 1, stroke patients needs rehabilitation within the first 6 months. They need rehabilitation like daily, literally daily, because neurons recover faster immediately after an injury. They have a window period of 6 months to recover to as near maximum or as near normal as possible. Now, our biggest challenge is we have settings where we have facilities that are available in urban areas, but patients who are in rural areas may not access these facilities. Now, my plea would be, let's have physiotherapy go down all to the grassroots level, where health centers would have physiotherapists that are able, again, and I underline this in bold, are knowledgeable about rehabilitation, because we have the basic knowledge, but we need to go deeper, get more knowledge in terms of rehabilitation, because through my experience, I've seen rehabilitation of stroke patients can go to 90% or almost 95%. And this is a person who can go back to work and work. But when we rehabilitate patients in such a manner that they're not able to work and they become like liabilities, that becomes a big challenge. So I would request if counties have the possibilities of having physiotherapists at the grassroots level, and continuous medical education is very important, because Learning is a continuous process, and we'll always get new knowledge every single time we go for training. Back to you, Mugire.
Dr. Naomi. Thank you, Dr. Naomi. Now, from Tilal Shah, after fracture of lumbar 1 and 2, can physiotherapy be done? What is the benefit?
After
fracture of lumbar 1 and 2, can physiotherapy be done? What is the benefit?
Of course, yes. After a fracture, and we are talking about the vertebral bones, some of the things that are expected is an injury to the nerves. Now, it can be at the central aspect of the nerve, it can be at the peripheral aspect of the nerve, depending on where the injury was or the fracture was. Now, rehabilitation can be done, whether it was a complete injury or it was not a complete injury. For a complete injury, we are looking at a regeneration of the nerves so that this patient can recover as near normal as possible. If it's a complete injury, we have rehabilitation of complete nerve injury, and therefore we are looking at a different direction in terms of how do we change this person's life to be as productive as possible. So physiotherapy can be done either way, whether a complete injury, nerve injury, or an incomplete nerve injury. Physiotherapy can be done and it's very beneficial. Back to you, Mugire.
Thank you very much, Dr. Naomi. I think some of the questions like now, the next one, Petronila Anyang. Petronila is asking, a patient, I think she means a patient with the rotator cuff muscle tear. How do we manage? That's back to you, Dr. Naomi.
Well, it's a good question, though not under stroke. A rotator cuff tear, it can be managed. It depends with the degree of tear. Is this a first degree? Is this a second degree? Is it a third degree? Now, depending on the degrees, if it's a third degree tear, that needs to be done surgery, and after which rehabilitation can be done. So still physiotherapy is relevant. First and second degree, still physiotherapy can be done in order to facilitate healing and acquire reduce pain and ensure that this person gets back the function of the shoulder joint. Back to you, Mugire.
Thank you very much. That's very true. And the most important thing when it comes to this rotator cuff muscle tear, especially the first and second degree, it's very important that adequate time should be given for recovery. And most times this is more or less like a sports kind of related kind of sports injury. So where you find that sometimes sports people are quickly running back to before they get full recovery. So my advice is that this kind of tears, they need to be given adequate time and good management, just as we have said, then before one is allowed full-time activity. Thank you very much. Now, the next question is, Dr. Naomi, from June Gasheri. How do you improve speech in stroke patients in terms of physiotherapy? I don't know whether we have our stroke pathologists on board, because we have a speech therapist. We have speech therapists within the hospital here, but can you try and answer that question, Dr. Naomi?
Thank you, Mugire. Now, it's like I said when I was starting, we work in an interdisciplinary concept. Now, when it comes to managing speech for stroke patients, that's basically not our job. It's good to do what we are trained to do. And because we have a speech therapist and a speech pathologist as well, so that is their responsibility. Now, the unfortunate part is that not every facility has a speech therapist or a speech and language pathologist, but the prudent thing to do is to refer that patient to where they can get a speech therapist. So, because I'm a believer of, let's do what we are trained to do and do it well, than struggling with things that we are never trained to do and just be a jack of all trade. So speech therapy is not our business. Back to you, Mugire.
For those who might not be aware, is that we have speech therapists within. In fact, we are very lucky that one of our physiotherapists trained as a speech therapist and is doing a good job within the hospital here. And now we have them elsewhere in other units. So consultation, we work in hand with consultation because that's a greater member of rehabilitation team. Now, I am seeing on the chat side, of course, there are people asking questions. There's somebody saying that has pain down the neck, going down, the radiating down. The other one is asking. So we have quite a number of which we might note on the chat side, Dr. Naomi. Yeah, but what I can say from my side and from our side, on behalf of my other colleagues who are out there, and if they feel like saying something, please raise your hand. I can say that stroke rehabilitation and stroke management is a collective responsibility in the disciplinary approach. Elsewhere, other people practice they have what they call stroke centers. And from what we see in literature is that there has been very quick and maybe positive outcomes better when patients are managed in stroke centers than in the general wards. I don't know what you have from your experience and from where you trained, Dr. Naomi, and from the literature, the latest, but from what I've been gathering is that sometimes there's been very positive results on patients managed in stroke centers. But the most important thing ever, as physiotherapists, occupational therapists, anybody involved in stroke management, is that we must come in as fast from the first day, and as you said, from the acute stage, and treatment and rehabilitation run concurrently. There's not a time you say you stop the treatment, then you start rehabilitation, but it runs concurrently. And as the patient progresses, more and more emphasis put on rehabilitation, back from the critical care units, high dependence units, general wards, outpatients, to home care, and involvement of the members of the family and the caregivers. At this juncture, we don't want to cut off the members of any member who would like to say or could ask anything again. But Dr. Naomi, in this case, I like the way you have tackled the shoulder management of the shoulder, especially spastic shoulder is a problem. And in fact, patient handling becomes a problem. I also like the way you have talked, although I would have wished one of the doctor participants to also talk about the use of medications, the central acting and peripheral acting, the use of solving, the use of baclofen, the use of diazepam. Okay, as physiotherapists, when we manage these patients and with the spasticity, we know we get a lot of problems. But the use of medications as well, so that we can be able to minimize the disability or contractures associated with the spasticity and etc. So far, so good. At this juncture, maybe I could just leave it open for any member who would like to ask another contribution or from Dr. Agnes.
Thank you very much for that session. We're actually winding up from the session, and we are really grateful for that very informative session. We have gotten a lot of feedback that it has been very informative. We might not be able to go into an open Q&A session right now, but really to bring this to a close. So I'd like to have our final comments from final comments from our chair, who has been Mr. Kennedy Mogire. He's the chief physiotherapist here at Kenyatta National Hospital and head of unit at the physiotherapy unit. And let's have his final comments and also final comments from our main presenter, Dr. Naomi Wanshirok Kingao, who's based at the Moi University, teaching in referral at the Orthopedics and Rehabilitation Center, and she has been able to give us very, very, very informative information on stroke rehabilitation. Over to you.
Thank you very much, Dr. Agnes. What I can say is that as physiotherapists in this country, as much as in general, I know quite a number of our colleagues who have taken a great interest, especially who are now pursuing even master's level in neuro rehabilitation, and the diploma level training is at Kenya Medical Training College. But in most times, patients who have survived the stroke need to be managed optimally. Dr. Naomi has dwelt much on the management of the upper limb, the management of the lower limb and the gait and the posture. What we know is that generally those who have survived stroke, they also suffer other general conditions like generalized fatigue, general fatigue. And also from literature, we also learned that most of these patients actually, because of sometimes lower, because of the involvement of the trunk, they tend even to consume more oxygen when they're even walking. In fact, other literature talk of up to around 50% compared to an ordinary person. So rehabilitation should not be, should be encompassed wholly or to address all the areas, including improving the vital capacity, and so that the patient can be able to move around without undue fatigue or stress. So far, so good at KNH. We are doing our best as we move to specialization. For instance, we have now Ward 7B, which is more neuromedical ward, and the management of stroke patients. Our physiotherapists come across these patients, and our doctors invite the physiotherapists from the ward go. We have had very good positive outcomes, and thanks a lot for this continuous the CME, because everything through research keeps changing, especially the management, where you are, Dr. Naomi has said, the discouragement of the use of overhead pulleys, the use of the sling, the cellular slings and such like. So these are all research informed. My challenge is to all my colleagues that we need to be involved on the day-to-day research, and as well as make sure that these people who have survived the stroke, they lead as back to their feet and they lead as much normal life as possible. All depends on us. It's a teamwork, interdisciplinary management, and also consultation where it's absolutely necessary. Thank you, Dr. Agnes. Back to you, Dr. Naomi.
Thank you, Dr. Agnes and Dr. Mugire, for giving me this opportunity to teach stroke and rehab. I'm really happy about that. And it's my sincere hope that when we get another opportunity, because there is so much that we need to cover about stroke. There's something that we've not covered. We've just covered the upper and the lower extremity. We need to talk about neglect. We need to talk about hemianopsia and all that, and many other things that we can we normally treat from for stroke patients. So there's so much we can cover. It's only that we didn't have time. I remember when we were doing training with Dr. Agnes, we actually had 2 days to talk about stroke, both theoretically and practically. So given an opportunity, we can always have time to learn. Knowledge never hurts. Thank you. Back to Dr. Agnes.
Thank you so much for that. Indeed, we need more time to do this, and we've seen the need even from the comments and the question, and this means that we'll need to plan another session. So we welcome you. We'll welcome you once again to this platform to just share out this knowledge. We might with even. I'm actually thinking we need to go ahead and even just arrange a whole symposium for this, because there's so much that we've not touched on. But we are really grateful for finding time to speak to us. We don't take it for granted. It has been very, very informative. For our participants, thank you for staying with us and for joining in. The presentation, once we have it, we can we'll upload it into our webinar, and even the recording, we'll have it on our platform, so you'll be able to hear again and again and even have the presentation. And in case of anything, you can always get in touch with us at the knhresearch@gmail.com, and we'll be able to respond to your questions and give you feedback. So we are coming to a close. We have upcoming sessions. Please feel welcome to join in the sessions like this one just uploaded right now, the KNH-UoN ERC Symposium. We have a session coming next week on person-centered respectful maternal care, which will be a series of each month session. So you're welcome to join in. Thank you, everyone. Have a lovely afternoon. Goodbye.
Thank you. Bye.